Ladies and gentlemen, thank you for your patience in holding. We now have your presenters in conference. Please be aware that each of your lines is in a listen-only mode. You may submit your questions electronically at any time during the presentation by using the Q&A window located to the left of the slideshow presentation. Underneath that, you'll see another window labeled Resources, where you may download a PDF copy of today's presentation. It is now my pleasure to introduce today's first presenter, AHA moderator, Drew Solo.
Welcome everyone to today's webinar. This is Drew Solo with the American Hospital Association, and I'm pleased to be moderating today's event, Optimizing Enterprise Patient Flow. Achieving operational excellence through enterprise-level transformation is critical to a hospital's effective performance. The intent is threefold: to improve workflows and protocols, advance care delivery, and support improved outcomes. Essential to ensuring the successful implementation of a sustainable process is the application of proven performance methodologies and clinical expertise alongside thoughtful data and intelligence and quality standards. Today's event will describe a systems approach to identifying performance improvement opportunities in an enterprise-wide patient flow. Relevant cases will be infused throughout the presentation to illustrate the salient points and help participants replicate these experiences in their day-to-day practice. With that, let me briefly introduce today's speakers. Debbie Sly is the Global Clinical Lead and Consulting Principal at Philips Healthcare Transformation Services. She is responsible for leading the development and delivery of clinical care solutions for Philips Healthcare globally. Debbie has developed an approach for clinical scenario planning through service modeling, capacity, and human resource planning. She has supported multiple organizations in building resilience in the face of the pandemic, as well as design clinical service lines for new and renovating healthcare organizations. Debbie has a strong technology background and is a global coach for organizations seeking to thrive during exponential change. She has successfully implemented strategies to optimize clinical practice from a multidisciplinary and continuum-based perspective, building on data to drive quality and experience outcomes. She is frequently selected to lead complex projects involving broad ecosystems where she is adept at leading divergent stakeholders into collaborative thinking. Our second speaker, Peggy A. Clifton, is the Senior Consulting Manager at Philips Healthcare Transformation Services. She is focused on performance improvement and leading clinical transformation projects that deliver impactful changes to client key performance indicators. She has partnered with clients to gain significant improvements in patient flow across the care continuum, including redesigning approaches to expedite patient throughput and eliminate avoidable delays and waits. Her clinical expertise spans adult and pediatric intensive care, bed management, perioperative services, as well as nursing administration. It is now my pleasure to turn the floor over to Debbie, who will begin our presentation.
As we are all intimately aware, COVID has really changed the way that people view and how we deliver healthcare. And if we've learned anything over the course of the last several months, we've learned that we really need to find better tools that help us to see what's coming and predict that demand and be more effective in managing what is predictable and more resilient in managing what is not. And as we look at healthcare systems today, some of the challenges that we're facing, and it's estimated that over 25% of the total cost of healthcare are frequently associated with failures in coordination of care and factors that are perceived as not providing value to patients or to the organization. And in addition to the futility of the administrative complexity, that's the peril for us all as clinicians and care providers, and all of these impacting the patient's experience with their health system, the patient's experience with their disease state, and possibly influencing their outcomes. But certainly the potential stickiness that they have in their engagement with us as a healthcare organization. So establishing effective clinical workflows is really paramount to optimizing patient throughput. And as I mentioned during this last year, more than a year now, we've learned a lot. We've learned about the peaks and valleys of care, that's for sure. But most importantly, we've also looked at the transitions between care. And these are the areas where that really warrant our attention, as most attention as it is in these spaces where progress can be stalled or blocked, or patients can fall through the cracks. And when hospitals battle to maintain the highest of quality, there's multiple areas that they might be attending to, and areas that impact the patient throughput. And we see these in a variety of engagements that we've been involved with, where executives, providers, and staff may not be aligned to a shared view of throughput, or where placing the patient in the most optimal care setting is quite challenging. And this results in people that are holding or boarding well too often. And failure to optimally allocate people to the next bed has been a real challenge for many organizations. Now, the promise of bundles and pathways, we still have struggled to achieve. And this has super potential in helping us optimize our throughput across the enterprise. But certainly, we have yet to realize the true value here. Now, organizing our post-acute care settings has also not come as easily as we might have hoped. And opportunities to reduce unnecessary stays and unnecessary durations in care has been significant. So, and when we look at that chain of care, we see upstream and downstream impacts where constraints might influence the patient volume and their ability to move through the system. Now, as I mentioned multiple times, really looking at predictable items is where we're focusing a lot of attention today, and how can we use data to do that better? And better synchronize the care with the patient demand and synchronize our support systems and our staffing. And it really comes down to variations in care management, which is the most important element that can influence outcome and also optimize patient flow. So with that, I will turn the presentation over to a polling question. So what is your key challenge? Is it prioritizing bed placements or engaging the care team in throughput, or the lack of an enterprise perspective? Or lastly, the inability to use actionable data in real time. So tell us, what is your biggest challenge? We see the numbers growing. I'll give you a few more seconds here. Okay, it's looking as though the most popular response is engaging the care team in throughput. So, and second in line is really using the challenges in using data to in real time to be actionable. So we'll try to put some emphasis in those areas as we go through the presentation, and I'll go ahead and turn the presentation over to Peggy.
Thank you very much, Debbie. So based on the polling questions, we see that engaging the care team is a concern for the majority of folks, as well as the data. So we'll try to focus on that throughout the presentation. And what we really wanted to stress is, as Debbie mentioned, due to COVID and the pandemic, it's really created even a higher emphasis on timely placement of patients in the right location for the clinical team based on the crisis that's been created in this situation. So what do we want to talk about with enterprise throughput? Are you approaching flow from a perspective that includes everyone, and does it represent that journey that your patient is experiencing? Since a lot of you are concerned about engaging your team across this journey, One of the things I would recommend when looking at enterprise throughput is how to bring all of the stakeholders together. Have the discussion about what does your journey look like. Are you able to build this journey, and do you have transparent data along the journey? Are all of the folks involved able to see transparently any interdependencies that are occurring, or what those bottlenecks are that are creating maybe some hiccups along the journey that's not allowing this patient to progress timely through the care continuum? Is some of your concerns about process? Is it about your workflow? Is it about having variations, as Debbie mentioned, with your throughput perspective? I think my slides are jumping. Just bear with me a moment. So enterprise throughput from patient arrival to discharge. We're all able to see how complex this is because of so many points of entry, the journey our patients take, so many different folks involved in the process, with everyone striving for a timely, effective experience for the patient through the continuum. And what is going to help us in that situation is looking at your culture, looking at your communication, looking at the collaboration that occurs among your team at your organization. How does your patient access your organization? And then once the patient is there, based on whatever entry point, how are they cared for? And how is that care coordinated? And I think today we can't stress enough the data-driven decision-making that needs to occur, which also requires you to have a transparent view of those key timestamps throughout the continuum that your patient is experiencing along the way. Now, we want to make this real for you and give you some real-life examples of things that have been successes. So if we're looking at data and we want to drive improvements across the continuum, then we want to leverage all of our stakeholders, and we want to look at what in your organization is unique. So you want to ask yourself, what data do I need to drive improvements? How am I going to incorporate efficiencies that I can manage throughout this continuum, get my entire care teams on board, and what are our real challenges? Because when we talk about enterprise throughput, it's the same common model or theory for everyone, but each individual organization has their unique issues and their unique items they need to drill down on to be able to gain successes and get improvements. So in this particular situation, the organization was able to gain momentum with improvement in critical care downgrades, a 48% improvement. So a lot of that was, involved having the team come together, look at how are we making bed assignments? Are we focusing on a particular type of patient all of the time? Are we always placing those patients in the emergency department first? And maybe the critical care downgrades aren't getting moved as efficiently? And why are we doing it that way? Are we not paying attention to next ready bed with next available patient? And what is going in the thinking behind that? Does everyone understand the upstream and downstream effect of what they're doing? So with this particular situation, bringing everyone around the table and talking about how their specific steps impact the continuum really enabled this particular client to gain some momentum with that. As well as in another situation, reducing length of stay, completely with the heightened focus on coordination of care. Now, that's easy enough to say, but we can all imagine the effort that went into this, looking at standardizing rounds, increasing physician and nursing engagement and flow, looking at having those physician champions and having the entire care team focusing on the length of stay, working with case management on what that should be throughout the continuum. And do you, again, have the data that helps you see into this process and allows you to manage this as everyone is driving toward the same goal? So if we want to look at identifying flow opportunities, hospitals have, and this really goes back to the first polling question about engaging your care team. A lot of you are struggling with that, and the New England Journal of Medicine pointed out a couple of years ago that operational changes are going to be the most successful when you have the cultural changes in place, and that's how you're going to gain momentum with improving patient flow. So how do you do that? You become very familiar with the major themes across the journey, as we've mentioned, and you map those out from all perspectives. Make sure everyone around the table understands, from the decision to admit to the patient being discharged, what is involved in that particular journey. You know, what data do you need? How are you going to get to the bottom of what's going on? And then what are those teams going to look like that are going to address these key pain points? So maybe when you're looking at poorly defined data and you're looking at lack of patient flow metrics, start digging into what points are measured and what additionally do you need to measure in order for you to be able to see if you're having any impact from your interventions. So if you want to really drive home, you know, are orders being batched on admission? Do you have discharge dates on admission? Does the whole team have an idea of when this patient really should be able to be discharged based on what's going on with their care team? Is the discharge order to actual discharge time being looked at? Does everyone understand what that goal is from when the physician writes the order to when the organization expects that patient to leave the organization? So with these, an example would be a pending discharge date. You would want 90% of your patients to have a pending discharge date at least 48 hours prior to discharge. And this is in addition to understanding on admission what that projected length of stay is for that patient. So everyone on the care team is operating under the same guidance, and they have the same vision for the timeline that's needed for this particular patient and the care that's needed. We move to the next slide, approach to capitalizing flow opportunities. So here we've listed a sample structure, and that's what you see at the bottom with leadership, process, structure, metrics, outcomes. You want to make sure you have a strong governance committee in place. We've talked about measuring the gap between current performance and where you want to be. Make sure you're able to measure what you're trying to impact and drill down and get to the level of detail where you can really make a change. The governance structure is going to help support these initiatives. This is much bigger than one or two departments. You really want to focus on having your executive champions, your physician champions, and all of the departments that touch these patients as they flow through the organization involved in this initiative. They want to be a part of looking at that anticipated discharge date, having subgroups that are involved in redesigning events that you want to change and make improvements in, and then how does that get reported back to governance? Looking at optimizing your existing IT, are you able to, see the data points that you want? We've mentioned that. Or do you need to have your IT team work on dashboards and having a little deeper view into some areas within the organization? And how do we make that data visible to those that need it? For optimal throughput, it's always good to look at the timely discharge process because it's easy to focus on what's broken or slightly bent in your organization. If you overlay that on top of your optimal throughput, get everyone on the same page about what we need to be doing, when we need to be doing it, you will have a strong foundation and build ownership and proactive planning with everyone involved. It goes back again to how do we bring accountability, coordination, communication, that collaboration piece, having folks bought into why we're doing this and what is their piece of this and why is that so important. By incorporating efficiencies, you can manage many things across the care continuum and sustain an optimized flow over time. And that's what you're trying to get everybody on board with. It's tough in the beginning. You have to drive the vision. And I'm going to just say once again, it's really going to depend on your governance structure, having your champions in place, and just constantly reminding folks what their role is, how they're impacting the bigger picture, and why we're doing this. And I've listed on the slides, we have examples of key things that are important to drive optimal throughput. Your proactive huddle is one of the key pieces. When you're discussing beds, you want to make sure you're actually accomplishing things in that bed huddle, and it's not really just a download on what's going on with the bed situation. We're full, we don't have any. You want to really be talking about how do we gain some traction, how do we get some movement, what needs to take place, and what's our follow-up going to be, and when are we going to get back together to discuss this. Looking at the process, standardizing those pieces that are a little bent or broken, as I've mentioned. Do you have a streamlined direct admission process? Can patients get into your organization, or do they always have to come through the emergency department and sort of clog up the portal of entry there for the ED patients? How are your physicians managing their rounding? Are they helping you expedite discharges, or are they saving those discharge patients until the end of their rounding? Does everyone have an idea of the length of stay? I can't stress that enough, because that really helps with bringing the team together and driving toward that same goal. And prioritization of placements is always key. We've mentioned that earlier, but really looking at, maybe what we're operating on today as far as our priority. We're doing ED patients first, then we're looking at transfers in, then we're placing the surgery patients. Maybe that doesn't work tomorrow for the book of business. Maybe tomorrow the prioritization is a little different because business looks a little different tomorrow, and we have unique challenges that need to be prioritized in a different manner. So if we talk about throughput costs, we have to quantify our successes, and we have to really illustrate, especially when you have governance in place and you're having folks report back on accomplishments, what they've been working on, how they're moving that metric. You want everyone around the table to have an appreciation for all the great work that's been done. So on this slide, we've listed quite a few things which are inefficiencies and can clog up your system. But if you really focus and you're able to put some dollars to this or quantify it to show successes, that will get you enormous traction across the organization. So, for example, your C-suite may be hearing in imaging there are patients that are waiting. There's just ED patients sitting, waiting to get possibly a plain film read, or maybe their CT completed. How are you going to approach that? Does everyone understand what that best practice is and what goal we're driving towards? The overall orders to results. Are we getting it within 30 minutes to an hour for these radiology films? Looking at prolonged bed turnover time. When housekeeping is done cleaning the bed, are they able to let the system electronically know that bed is clean and ready, or does that take a long time? Looking at every little piece of information and how it's communicated can allow you to gain efficiencies. In the emergency department, if we want to look at door-to-balloon time, what does that really mean? And does everyone around the table understand that we want to focus on 30 minutes in the ED, but that includes 30 minutes once they get to the lab, 30 minutes in the field before they get to the ED, understanding that upstream and downstream impact. And in peri-op, looking at cancellations, or, do we have them within the 3 to 4% range where they need to be? How is that impacting business that day when a lot of cases are canceled? Or on the flip side of that, if you're scheduling and you do not have the case times where they need to be, your day will be very inefficient and run over, and things won't go as planned. All of these inefficiencies begin to add up. When you're looking at getting someone out of the PACU or even inpatients moving from one location to the next, is transport able to retrieve that patient and move them to the next location within 15 minutes? Or are they taking a little longer to get there? So as each issue begins to delay across this continuum, the impact is accentuated as the day progresses. And you really want to tease these out, get to the bottom of them, and begin quantifying them, because folks will understand how you've opened capacity. And, you know, when you capture transfer volumes because you've opened capacity by improving your efficiencies, that will be a good way to bring in revenue. Sometimes it's a revenue growth opportunity versus cost savings. When you're looking at reducing your length of stay, that causes, efficiencies will cause a decrease in length of stay, but then you have the opportunity to backfill that because you've opened up the capacity for another patient. So just encourage you to think about the multiple outcome metrics that can be used to achieve ROI, and that speaks quite a bit to the improvements that have been made. Let's go to another slide where we'll share some successes. So leveraging analytics, looking at custom dashboards. Are you able to track patients experiencing extended throughput times? Here we were able to capture a 31% reduction in a timestamp, a very specific timestamp. So we looked at bed request to inpatient bed assignment from the ED, and was that within 30 minutes as best practice states? It wasn't at the time, but we were able to gain 31% traction on that, and an improvement, which was much needed. Also, looking at, sometimes you can roll your successes with your initiatives, kind of bundle them together just by impacting something large like staffing alignment, and you're able to avoid an additional expenditure by focusing on efficiencies and improvements with throughput times, looking at acuity levels, how your nurses are staffed, the left without being seen by physicians. Is it where it needs to be at less than 2% or at 2%? Let's talk a little bit more about best practices to drive improvement targets. I have a quote here from the Joint Commission, which is really the National Patient Safety Goal number 2, which is talking about critical results and the timely reporting of those. But it's really key here as well, because best practices and driving improvements have to be timely as well, and it is all about the effectiveness of the communication that you have with the care team. So we're going to go to a polling question now, our polling question number 2. What has been the most valuable initiative you have implemented to improve your surge capacity? Is it A, process and workflow changes, B, technology-enabled dashboards, C, discharge support teams, or D, frontline flow coordinators? And I think we're all able to see as the results are coming in, process and workflow changes are getting the highest percentage of responses, around 69%. And some are saying at about 15% that discharge support teams have helped as well. All of these are key to driving improvements. I would say process and workflow changes here appear to be the highest among our attendees. The next slide. So we've spoken a lot about measuring success and having a transparent view into the metrics. I think paying attention to what's unique in your organization and looking at what you want to measure and maybe a few other metric points that let you know if you're getting close to moving that larger data point. If you don't have enough beds for your surgery patients during the week, and you're always saying on Tuesdays that you need orthopedic beds, then taking a look over the weekend to see how we're getting patients discharged out could be an early indicator of opening up those beds for your patients on that surgery schedule. So all of these key boarding hours and average length of stay, looking at your ICU patients, we mentioned downgrading to open up capacity as needed. Looking at discharges by noon is key as well. But also I would encourage you to look at any traction you're gaining on discharges throughout the day by time of day, because that will give you insight into the movement in your organization and give you some idea of the actual improvements and some of the areas where you are seeing things change, and then work from there. It's very challenging to go from your current state to a future state, which is best practice. I would suggest having those intermittent goals, or those goals between where you are and getting to best practice, and then celebrating with the team once you get to those in more of a baby step type fashion. If we look at more throughput best practices, you want to drive your improvements based on what you want your desired outcomes to be. So it's very easy to say you're going to optimize admissions and care coordination, and you're going to share that with the team. But we need to get down into the details so everyone understands what that means and how you're going to do it. So you're going to develop and adhere to admission criteria. Everyone's going to have an understanding of how we're going to approach soft admits and how we're addressing external transfers. That needs to be a key piece of prioritizing the beds. That brings in revenue for the organization, and we can't have the transfers not coming in because we can't make a bed for them. We have to sort of do that prioritization and make sure every type of patient that needs to get into the organization is coming in. So if we look at advancing clinical decision support capabilities, are you driving awareness for early deterioration with what's going on with your patients? Can you promote discharge readiness? And as Debbie mentioned, have that predictive capability or predictive planning based on some algorithms that gives you an idea of what's going on with your patient population across the organization. Technology-enabled triggers for barriers to discharge are always a great way to get everybody on the same page. It's going to alert you to specific factors that impact discharge, gives people an idea of what's left to be done to actually get the patient discharged. And optimizing discharge planning. Give people the tools they need for visibility, communication, and collaboration to drive improvement. How often have we been to rounds and everyone is working from a stack of papers? You know, is it possible to have folks more often than not on tablets and actually getting things done during the meeting and progressing that care in the moment while we're talking about that patient? And then looking at expanding care coordination to across the continuum, going back to predicting the potential admissions on the front end, prioritizing those transitions in care, and how are you going to manage flow forward to the post-acute settings? How are you going to become creative in getting your patients out the door when they need to be out the door to that next level of care? High priority environments for orchestrating care. So this is a really good snapshot of areas that are impacted that are clinical, operational, technical. We have metrics lined up here. It shows you the inflow and outflow in the organization. Again, stressing collaboration, transformation, technology enablement. So what you want to do in these areas, going back to your unique characteristics in your organization. So if we start in the emergency department, we've mentioned the left without being seen. Is that at the percentage that you want it to be? Where is it? First of all, what's your current practice? Where do you want to get to based on best practices being around 2%? And looking at those patients, staffing for peak times in the ED by time of day or day of week or time of year even, and maybe taking a deeper look into the patients that did leave. Do they return? Or are their needs met in a clinic setting? And maybe that's why they came to the ED to begin with. They were unable to get into your clinic. We look at diagnostic services in the second column. Room turnarounds can be very key in this area. I mentioned earlier ED patients waiting for CT. So what's going on in imaging? And how are they prioritizing their patients within imaging? You've got your inpatients and your outpatients, and how are they working in the patients that need to be seen from the ED, looking at that average time from order to scan complete? And are we driving toward best practices? If we have someone with oral contrast, are we getting that done within 79 minutes, or no contrast within 49 minutes? Within surgical services, looking at room utilization, do we have turnover times, and do we have the schedule flexible enough to get those urgent and emergent patients that need to be added onto that surgery schedule so we can keep the care flowing through the organization? Are the nursing units able to have an understanding of the anticipated discharge date? Are they aware of this? Does it get selected on admission? Is there a flag for readmissions? Is everyone on the care team aware of what's going on with this specific patient and how we need to possibly look at, how do we make this a successful discharge this time and help them not get readmitted or bounce back, so to speak? Because you want to work on that readmit rate for the org. Is it where you want it, between 4 and 6%? And then care coordination overall, just looking at when your discharge order is written to when your patient actually gets out the door. Are you doing what the goal is for your organization? And if not, how do you tease that out? Has your goal been set at 3 hours once the discharge order is written to the patient physically leaves the organization and is discharged? And if not, if that's not occurring in 3 hours, how do we figure out what's going on there? And again, you're going to need everyone around the table reporting up through governance to say, here's what's going on with our initiatives, here are our metrics, here's how we're managing these initiatives, and here are the successes that we've gained to date, but we still need to maybe look in a few other places to see what's creating a bottleneck or slowing things down a little bit. So we'll, on this slide again, discuss some successes. So when we look at opening available capacity, again, this is bringing everyone around the table and having them understand their role in the big picture. So improving throughput is impacted greatly when you're able to reduce any type of boarding that goes on in the ED or the PACU, especially if some of this excess time is related to turnover time by other departments trying to get ready for that patient, to get that patient where the patient needs to go. Having the workflow alignment. Are we staffing our areas during peak times? And are we watching the peak times to see if they change and maybe adjusting staffing further? Oftentimes, it requires more than one adjustment. There's never one true, we're going to do this and then that's going to work and we don't need to revisit it. It's a dynamic process. We have to keep going back to make sure we're getting the outcomes that we want. So if we look at a 47% reduction for this particular organization, we looked at eliminating bed holds. Are we allowing beds to sit empty for outpatient services like the cath lab, or are we really placing the next patient in the next available bed and removing those unintentional delays? Oftentimes, we may think it's a great idea to hold a bed for the first cath lab patient of the day, and that sits empty all night, but that may not be in the best interest of your patients that you have waiting in the ED. When there's time during the day to get another patient discharged, open up another bed somewhere for that cath lab patient. So it's looking at how to best align that supply and demand for your beds, for your organization. With a 24% reduction in emergency department orders, similar concepts. Are we upgrading and downgrading? Are we opening that capacity? Do we have a bed matrix in place where everyone involved in making bed assignments understands the 3 priorities or the top 3 to 5 priorities from a particular specialty for where they want their patients placed? So we're able to get them in a bed so they can get to that next level and have care uninterrupted. So I'd like to now transition this back over to Debbie, and she'll talk to us about sustaining optimized flow.
Thank you, Peggy. And this quote, I think, is particularly relevant. So, what got you here will not get you there. We've come a long way in better managing our throughput, but we have a long ways to go. And so successfully getting there will require to not only build on what is working, but really thinking about new ways of working, to foresee, new roles in care coordination, to embed some adeptness in how we use technology, not only for clinicians, but also on the part of the patient. And what we've really seen lately is the patient taking a much more active role as a lot of the care has become virtual, and they've begun to own a bigger part of their care process. So really working on redundancy and adopting new ways of working is critical, but letting go of the old is even more critical. Too often in healthcare, we end up keeping it all, and we really have to focus on what's the best way of doing things. And that comes to the point of change management, and how do we manage the transition between maybe an old way of working and a new way of working? How do we help people adopt, and how do we facilitate and monitor the successes? And we see, as in many models, there's a threefold process: engaging, transitioning, and sustaining. But starting with the individual, and then maybe moving to a team level, and ultimately for the whole organization. So when we're trying to drive and sustain the improvements, there is a path forward. And we've talked a bit about data and how data can help there. So measuring and monitoring of the key variables. This is one of the elements that we think is most critical in helping physicians and other clinicians really see their own performance and measure that against others, because they may not even realize the impact of some of their decisions, thinking that they're doing the best on behalf of the patient, but perhaps it's influencing the patient outcomes in an opposite direction. And rapidly evaluating, being agile, being flexible, being resilient, whatever is the word of the day, evaluating and course correcting is really critical. Feeding back those lessons learned, we have so many of them, but really optimizing in a continual way until we really have achieved all of the desired benefits. So as you've thought about what we've been saying so far, we just have one final polling question. So what do you think will have the biggest impact on throughput just in the coming year? Will it be predictive models to better anticipate demand? Will it be centralizing some of your care collaboration, maybe into common centers? Or orchestrating personalized care across populations? Or will virtual care become the area that we really need to focus? Okay, so we see some trends in the first two, predictive modeling and centralizing care collaboration. That's great, because that fits right along with my next slide and the last slide of the formal presentation. So as we envision this future of collaborative care, we do see technology playing a key role. But as we all know, it's all about the people. So how do we use the data, use the technology to help people make better decisions, have actionable insights? We do a lot of work in dashboarding and command centers and presentation, visualization of data, but it's really about what are the processes that people put in place, as you've said, to make this data actionable. Now, whether centrally means in a common place or whether centrally means just that everything is available to everybody from no matter where they are, is really about how do we collaborate and how do we use data to move the patient forward. We'll see more and more the use of artificial intelligence or machine learning to be able to give us ideas about the past realities and how that performance influences future performance. How do we make performance more transparent so that we're all able to learn from what's been done in the past to set the stage for what we can predict coming forward? And I think one of the major challenges that people have is trying to figure out what are those critical data elements that make a difference. If you can only look at a few things, what gives you that high index of suspicion that you're going to have a surge situation on your doorstep, or you have a major bottleneck coming up, or constraint that you should pay attention to relieve some upstream or downstream impact. So all of these brought together is really about care collaboration and maybe using technology to enable that. So with that, we'd like to open the presentation for questions.
Great. Thank you, Debbie and Peggy, for your presentation. We will now begin the question and answer portion of today's event. As a reminder, you may submit a question for our speakers in the question and answer box to the left of the presentation. Simply type your question in the box and hit submit. Our speakers will answer as many questions as possible in the time remaining. Questions that are unable to be answered in our allotted time will be shared with the speakers for follow-up offline. So first question, Debbie, this one is, I think, best geared towards you. Debbie, who or what is the biggest influencer of efficient throughput, and how do you change behavior and incorporate more buy-in or adoption of throughput initiatives?
Well, that fits into what I was just saying. So it's again all about the people. It's changing the mindsets of people, those people being ourselves, myself as a clinician, my colleagues as physicians and nurses and other care providers, and also the mindset of the patients and families, setting the right expectations so that we're all marching to the same theme. And as I've mentioned, how you really, adopt that change or how you really sustain that change is having the right data that demonstrates what our performance has been and what it is currently showing, so that we can see in a real actionable way where we should focus our attention and how we're measuring up. So those are the key elements that I see, is really changing our mindset and perhaps using data to inform better decisions.
Great, thank you. Next question is for Peggy. Peggy, do your data analytics processes support physician involvement with data validation regarding the throughput performance?
Yes, so I think this is key. I think I mentioned throughout having a physician champion as well as an executive champion. And in order to have a physician champion, we really need them involved in vetting the data. They need to understand the data, be comfortable with where it's coming from, have an appreciation for data integrity, feel what's being reported to them is accurately reflecting their practice and what's going on with their patients, and they're able to speak easily and have an understanding of what their performance is with their patient population. I think that's key. I think when our data has issues and our physicians aren't on board, we definitely lose a lot of credibility with our physicians, and our physicians are key to helping us, to partnering with us and driving this.
Great, thank you. Peggy, another question for you. Can you tell us more about how nursing units can measure their care management processes? Sure.
So I think where my mind goes with this, care management processes can mean a lot of different things. So hopefully I'll be able to answer this and get to the bottom of the issue. So I think of clinical milestones. I think of what needs to happen in the patient journey that has to make it a productive day on this nursing unit for this patient. And the staff are able to see, the physicians, the nurses, the case managers, everyone involved, they're able to see that the patient is progressing in their care plan. So do you have the particular clinical milestones set up for your unit and everyone's familiar, new nurses to seasoned nurses, do we have an understanding on the oncology unit that your patient is going to need to make sure they can tolerate a meal before they leave? That's always key. Is there a particular medication your patient needs before they're able to be discharged? On another unit, possibly you send patients home a lot that need IV medications. Will they have the PICC line placed the day of discharge? And if so, how are we all coordinating that early on so the discharge isn't delayed? It's really looking at how do I get medications, we often say meds to bed. How do I get those medications the patient needs for discharge to them in a timely fashion so we are coordinating this discharge in a way that we are very efficient? And so I think it's understanding those pieces and parts to the care pathway with your patient population, and is everyone focusing in on that, and also paying attention to, are you a particular unit just based on how ill your patients are that they have the potential to come back or bounce back, so to speak, with readmissions. So I would say just paying attention to your population and knowing those milestones and having everybody track along with that particular patient.
Okay, great. I have a question here for Debbie. Debbie, what's your recommendation for managing the transitions between care environments to ensure patients don't lose momentum in their journey?
Well, I know that a lot of you found that processes were really where you were focusing a lot of your improvement initiatives. But really, I see the concept of that patient coordinator, that patient navigator, the care coordinator who is monitoring the entire pathway and paying particular attention to the gaps between the departments or the gaps between the phases of care. When I was a care coordinator, I spent all my time in those spaces because I trust the clinicians in their individual phase and their individual departments to do the best that they can do. But my role as a care coordinator is to really manage that interface between departments. So I guess the key answer is tasking somebody with it. Number one, focus on those transitions and educate everybody along the journey, make sure that they understand their part to play in their own department or their phase of care, but help them understand the impact of what's going on in their department, what impact that has on the prior or the following phase of care or the next in line, so that we think not only about ourselves, but we think about those transitions. So I think it's really having somebody tasked with it and helping people change their mindset around how important the handovers are between departments.
Great. Peggy, what is the medical staff's path for reviewing data? Are there current environments or situations where physicians have the opportunity to discuss throughput metrics?
So I'm glad you asked this. I think this is a key question, again, for having credibility with our physicians, having them involved in the business of throughput across the enterprise. And when you do have a great flow governance in place or have that governance structure, so to speak, this is a great place for metrics to be reviewed. Also, before you get to that point, your physicians should be very familiar with their key metrics and understanding where they're coming from, as I mentioned before, and what their performance is within the organization. And, in a very professional manner, how that bumps up against others, because a little bit of professional competition is always good, right? So looking at having them involved is key. And they are then able to be advocates for throughput and share with their colleagues peer-to-peer on what we're all driving towards in the best interest of our patients and the care they're receiving across the continuum. So I think this is a very important piece. And if you don't have that in place now, I would suggest trying to find that way to have this opportunity with your physicians to make sure we're meeting their needs as well and they have what they need to be champions out there and help us with this throughput.
Great. Debbie, how can we best model the impact of new pathways on patient throughput before we implement them?
Well, I think we all have varying levels of maturity or capacity and capability in terms of how we do modeling. And modeling can be ever so simple, just walk through the journey. Just go from step to step yourself or with your group and see, visualize, act out the different scenarios that might happen as a real patient goes through that journey. Observe patients, observe flows, observe what those challenges are. It can start so simple as that, or it can become very sophisticated in terms of actual simulation tools or capacity and demand planning tools, calculating tools. We have a number of these that we use with different organizations to help them actually calculate what the impacts might be if they change this variable or if they lengthen this phase but reduce this phase of care. And as we see technology moving further, we're getting into things called, like, for example, a digital twin for an organization. How do we take the data about an organization sort of offline and play with it and try to tweak different situations that we're trying to model through a particular pathway? So I think the key is that you don't have to have the highest of technology support. You can start extremely basic and just simply walk through all the way up to using some calculation tools to visualize the impacts of changing one variable or another, some simulation tools so that you can see visually how people flow through the organization and where the bottlenecks might be, and then all the way up to the more advanced technologies that I think will be coming before you know it, where we're able to take the organization offline, such as in that case of creating a digital twin for our organization and using it as a sandbox to play with.
Great. Question for Peggy. Peggy, one of their biggest challenges was getting bedside staff to see the importance to safe patient care. Do you have any suggestions or advice around this?
Yes, so I think this is a big challenge. And what I find often works is staff need to feel heard, and I'm sure you are already listening to them. It's not that you're not. But if you can bring them along in the redesign, what is their role in what you're trying to change? Make time for them to voice their concerns about what isn't working and what might be in the best interest of flow for the patient, and make sure they're at the table and they can help you build that future state and what that would look like. Once staff feel heard and have some of their needs met and have an understanding of where these initiatives are going, again, going back to that piece of upstream and downstream, it becomes more of a teaming effort. And especially if we can get some things in place for them that make their day a little easier. Sometimes staff are very overwhelmed with many tasks, and if there's something that we can help streamline for them initially and then get things running a little smoother for them, they do have a little bit more time to then see, okay, I want to do the right thing for my patient. We all want to do the right things for our patients. Let's all pull in the same direction. So bring them along with the redesign.
Great. Well, that concludes the time we have available today for questions. In the next few days, all attendees will receive an email that will include a link to the archived webinar session. Thank you to our audience for joining us, and thank you, Debbie Sly and Peggy Clifton, for your presentation. Thank you to our sponsor, Philips. Thanks again for joining. This concludes today's program. Have a wonderful afternoon.
Ladies and gentlemen, that concludes today's presentation. You may disconnect your phone lines, log off your webinars, and thank you for joining us today.